bevacizumab is an important addition to chemotherapy for some patients. The challenge is that despite it being around for over a decade, we haven't really figured out how to best identify which patients have the significant benefit from it. We know from ECOG 4599 that when bevacizumab was added to carboplatin paclitaxel, it significantly more than doubled the response rate. It improved the progression-free survival, and it also did that in combination with cisplatin gemcitabine. It improved overall survival when added to carboplatin paclitaxel, but not with cisplatin gemcitabine, and we don't know how much it impacts survival when added to platinum pemetrexed. So it's a bit mixed. We know that there's definitely a group of patients that have significant benefit. I have one patient in my practice. She's been on maintenance bevacizumab now for 4 years. She had significant liver metastases and had a beautiful response and has not had any progression for all that time. So there's something about her tumor that makes her specifically sensitive to it, but we don't know what that is. And there are other cases like that if you talk to people in practice. So with bevacizumab, it adds, but at some cost of toxicity, risk for bleeding, risk for hypertension. We know that those risks are higher as people are older. We know that they're higher if they have underlying hypertension. It can increase the risk for cardiac events or stroke, though those numbers are fairly small. So it's like everything we do, there's a risk-benefit discussion with the patient. This is a likelihood of it helping, this is a likelihood of it harming. And as a patient becomes more frail, the harm risk goes higher. As the disease burden goes up, the benefit goes up. So it's trying to find that where there's that balance way out for that individual patient and making the decision. In deciding about chemotherapy doublets, there are a lot of factors that go into it. I will occasionally give cisplatin to patients who are younger, fit, really want to be as aggressive as possible because there is data that cisplatin has a higher response rate than carboplatin. Then when I'm trying to figure out what do I pair with the platinum doublet, as part of that doublet, there are a lot of factors that go into that as well. With adenocarcinoma, I use more pemetrexed because of the tolerability profile, no hair loss, limited nausea, you don't end up with neuropathy usually, and there's good data supporting its efficacy. It also seems to work particularly well in some of the molecular driver subsets, such as RET and ROS and ALK. So that tends to be my preference. But then if I think about adding in bevacizumab, it's less clear how much the bevacizumab adds to pemetrexed. We'll have more of that data when we get the ECOG maintenance trial that was looking at maintenance with either bev or pemetrexed or both, but we don't know that answer yet. With other platinum doublets, if I'm going to use carboplatin with paclitaxel, I'll usually think about adding bevacizumab because that's where we have the strongest data of the additive benefit with bevacizumab. If I'm giving gemcitabine, which I don't tend to do so often except in a squamous setting, in a patient with squamous histology, I'm not going to give bevacizumab. So if I'm giving gemcitabine to a patient who does not have squamous histology, maybe it's renal function or something like that, occasionally I'll add bevacizumab to it, but not very often. We do have good safety data, good efficacy data, and that's from the AVAIL trial, but we don't have clear survival benefit from that trial. When I'm treating a patient with a platinum doublet, I usually aim to give them 4 cycles of that doublet. Occasionally we'll go to 6. I warn patients from the beginning, talk with them about the fact that we're going to aim for 4, that I will consider 6 only if we see the tumor is still shrinking and if they're tolerating it well. But that in general, even if a patient's feeling okay after 4 cycles and we try to get in 5 and 6, we start having more issues with neutropenia, thrombocytopenia, and so it becomes more and more challenging to do that, and that's why we tend to stop at 4. If a patient's getting a platinum doublet with a taxane, I don't tend to continue the taxane in a maintenance setting. However, there is an ongoing trial looking at maintenance with nab-paclitaxel, and if that comes out positive, I might consider it in that setting. We know that if a patient's getting a platinum doublet with pemetrexed, that maintenance pemetrexed is superior to not giving maintenance pemetrexed. So I will always give maintenance pemetrexed unless there's a toxicity reason not to. If I'm giving a platinum doublet with gemcitabine, I personally tend to give gemcitabine as maintenance, but there's a lot more controversy there. The data is positive in an older trial in Europe, not as clear in some other studies, and so there's a lot of differences of opinion about what's the right way to go with that. If I give bevacizumab, I always continue it as maintenance. That's how it's been done in every trial so far. The ECOG maintenance trial, which is we don't have the results from yet, is looking at that question of whether we can stop it after giving the 4 cycles of a platinum doublet with bevacizumab, but we don't know that yet. There's also a question of whether we should give pemetrexed and bevacizumab together as maintenance. There's been some data supporting that approach. And so if I've given platinum with pemetrexed and bevacizumab together for a patient, which I will do sometimes, I tend to continue both drugs together as maintenance. When I'm starting a patient on platinum doublet chemotherapy, I tend to get a scan after they've had the first 2 cycles because I don't want to be in a situation of not knowing if that combination of drugs is helping the patient. Sometimes clinically we know that they're either getting better or worse, and then moving out another cycle or 2 to get the scans is reasonable, or moving up the scans if the patient's clearly progressing. There's some variations in practice, and scanning after 3 cycles as opposed to 2 I think is reasonable, but I tend to do it after the first 2. And then I do it after the next 2, so they've had their 4 cycles, because that's the initiation of maintenance, and I want to know what's the baseline. Once a patient's on maintenance, I tend to get scans every 9 weeks or so that's after 3 cycles usually, so a little bit over 2 months. And as long as the patient's on active treatment and it's chemo, I usually tend to be getting scans about every 2 months. We'll sometimes switch to 3 if they've been doing well for a long time and they really hate scans, or there are various reasons to think about that. If a patient's on a targeted agent, which isn't this case, I will initially get the scan after about 2 months, and then if they're clearly responding, I'll switch to 3 months, unless there's a reason we're suspicious that it's not working as well any longer. There's some variation in that, but that tends to be my practice. I also tend to get CT scans and not as many PET scans. PET scans are most useful if the patient has bone metastases or something else we're not going to be able to track as well with the CT, but it adds a lot of additional radiation, and very rarely does it change our impression beyond what the CT shows, so I tend to get fewer of those, but that's another area where there's some controversy.